بسم الله الرحمن الرحيم. ان شاء الله هنبدأ في المحاضرة الثانية. احنا المحاضرة اللي فاتت خدناها اللي هي الماكسيلاري فراكشر. هنبدأ في تاني محاضرة اللي هي الزيجوماتيك كومبلكس فراكشر او بنسميها زي ام سي، زيجوماتيك وماكسيلاري كومبلكس فراكشر. هنبدأ بفيزيولوجيكال اناتومي. لو لاحظنا هنلاقي الزيجوماتيك بون that forms the prominent part of the cheek، عشان كده احنا بنسميه cheek bone or malar bone. It is diamond shape or star shape او بنسميها quadrangular in shape. Have four processes. The first process is the fronto-sphenoidal process that articulate with the frontal bone and the sphenoidal bone. The second process is the temporal process of zygomatic bone that forms the anterior one-third of the zygomatic arch. And the third process is the orbital process that articulate with the maxillary bone to form the inferior orbital rim and the inferior orbital floor. And the fourth one is the maxillary process. This is the shape of zygomatic bone. It is quadrangular in shape. Quadrangular in shape. It is the fronto-sphenoidal process. It articulates from medially, from laterally to the sphenoidal with the frontal bone, and from inside to the sphenoidal bone. This is the temporal process of zygomatic bone that forms the anterior one-third of zygomatic arch, and this is the orbital process that articulates with the maxillary bone, and the last one is the maxillary process that articulate with the maxillary bone. Again, it is the zygomatic bone that form the prominent part of the cheek, so it is called malar bone or cheek. It forms the inferior orbital rim and with the maxillary bone to form the inferior orbital rim and a large part of the floor of the orbit, okay, and also it forms with the frontal and sphenoidal bone the lateral orbital rim and the lateral orbital wall. Etiology: due to the prominent position location of the zygomatic bone, it is prone to fracture, and the main cause of fracture is through road traffic accidents. Also we have interpersonal violence or assaults. We have falls and work and sport injury. In most of literature, zygomatic maxillary fracture is second only to nasal fracture. Some literatures document that the zygomatic maxillary fracture (ZMC) as the third after the nasal and mandibular fractures. We have many terminology to zygomatic bone fracture. First is the fracture zygoma. It is okay. Old terminology is tripod fracture, and this is our trimanar fracture, and it is inaccurate because the zygomatic bone have four processes, not three processes. Okay, we have tetrapod fracture, we have zygomatic complex fracture, we have zygomatic maxillary complex fracture, which is called ZMC, and it is the most common used name is ZMC. Okay, classification: we have many classification to zygomatic bone fracture. The most common classification is we have Roux classification, and Roux classified zygomatic fracture according to the stability after reduction to stable after reduction and unstable after reduction. Stable after reduction, we have rotation around the vertical axis. It means that medially or laterally we have medially displaced zygomatic arch. And zygomatic bone fracture unstable after reduction, we have rotation around the horizontal axis. We have dislocation on blocks inferiorly, laterally, or medially. Inferior displaced zygomatic arch and comminuted body fracture. Another classification is Knight and Dorsey classification in 1961. We have night and North classification, and this classification depends on the analysis of Waters' view, and he classify the zygomatic fracture into 6 classes or 6 groups. The first group is no significant displacement. The second group is zygomatic arch fracture. Third class is unrotated body fracture. Group 4 is medially rotated body fractures. Group 5 is lateral rotated body fractures. Group 6 is complex fracture. It means that presence of additional fracture lines across the main fragments, or it is called comminuted fracture. We have two classifications based on CT analysis, which is Manson classification in 1990, okay, and we have Zing and Kulik classification. In Manson classification, he classify the zygomatic fracture according to the severity of the trauma into low energy zygomatic fracture, and there is a little or no displacement. And we have middle energy zygomatic fracture. We have fracture at all processes or buttresses of the zygomatic bone itself and result from middle energy trauma. And we have high energy zygomatic fracture from its name. It results from high energy trauma, and we have that fracture in 4 processes, okay, with comminution to zygomatic bone itself, and have another fracture of facial bone. It is called van facial fractures, okay. The last classification is Zing and Kulik classification, and he classifies zygomatic fracture into type A, type B, and type C, and it results from high energy forces. Signs and symptoms. We have periorbital ecchymosis and edema. It is called the black eye or raccoon eye. We have flattening of the malar process, okay. We have also displacement of zygomatic arch, flattening of the cheek area, okay. We have pain and tenderness. We have step deformity in the inferior orbital rim, also in the lateral eyebrow area, frontozygomatic suture. We have also in the zygomatic-maxillary suture from inside or intraorally, okay. We have subconjunctival hemorrhage, okay. Also, maybe due to displacement of the eye, we have unequal visual levels, which it is called dystopia. We have what it is called antimyoclonic slant. Antimyoclonic slant, it is downward movement of the eye, lateral canthus of the eye, so it is gives the appearance of antimyoclonic slant. It results from fracture above the retinal tubercle. Retinal tubercle, it is a tubercle present in the lateral orbital rim, okay, and attached to it is the lateral canthus of the eye and lookwood triangle or lookwood ligament, okay. So fracture above this area leading to displacement of the lateral orbital rim downward and resulting in antimyoclonic slant, okay. We have also diplopia and enophthalmos. Clinical examination during to palpation, okay, and visual examination. We have to examine eye movement, okay. We have diplopia and pupil reaction. What is mean of enophthalmos? Enophthalmos mean inferior and posterior displacement of the globe of the eye. It means that sinking of the eye. It is an common complication of the zygomatic fracture. It is about 4% to 9% of patients with midfacial fracture or zygomatic fracture. It results from, first, decrease the size of the orbit due to dehiscence of the orbital contents like orbital fat escape in the maxillary sinus or the osmoidal sinuses, okay, or increase the size of the orbit itself due to the fracture of the orbital wall, okay, like this picture. Our result from entrapment of the muscle and backward traction of the glute due to the entrapment of the ligament or the muscle. This is the cause of enophthalmos. So clinically, enophthalmos less than 2 mm not need treatment. More than 3 mm is need treatment. Very important. Diplopia. We have two types of diplopia. Diplopia is a blurred double vision. Okay. And we have two types of diplopia. It may be mononuclear diplopia or binuclear diplopia. What is meaning of mononuclear diplopia? Mononuclear diplopia, it is a double vision through one eye. While the other eye is closed, we can see diplopia. It may result from a severe trauma to the orbital contents, resulting in detached lens or fractured lens or injury to the globe itself, of the eye itself. Okay, binuclear diplopia is the most commonly happened with zygomatic complex fracture. It may be result in 10 to 40% of zygomatic injuries. And binuclear diplopia, it is diplopia when seeing or looking through both eyes. It results mainly from asynchronous movement of the muscle. There is no synchronous between the movement of the two eyes. Okay, so the main cause is the trauma to the muscles, extraocular muscles of the eye. We have 6 extraocular muscles of the eye. Okay, may be result from intramuscular hematoma or edema of one or more of the extraocular muscles. Okay, we have 6 extraocular muscles. Disturbance of the attachment of the inferior rectus or inferior oblique muscle or periorbital tissue, entrapment in the fracture segment, injury to the cranial nerve 3, 4, and 6. Okay, so this is the extraocular muscles of the eye. Okay, so binuclear diplopia not occurs in all gazes of the vision. Okay, it is most commonly in orbital floor fracture or entrapment of the inferior rectus muscle in the floor of the orbit. Binuclear diplopia occur in upward and lateral gaze of the vision. Okay, very important. Not all gazes will have diplopia, only one or two gazes according to the affected muscle. Like this picture, these patients have right zygomatic complex fracture, and there is entrapment of the inferior rectus muscle in the fractured floor of the orbit. So when he looking upward and laterally, this eye moved freely and this eye not moved to this position, so there will be diplopia, binuclear diplopia, when he opened both eyes. This test is used, it is called force reduction test. It is used to determine if the muscle is entrapped or not. Okay, by a tooth tweezer, and we can catch the insertion of the muscle in the conjunctiva of the eye, and by move it or tract it. If the muscle is tracked freely and the eye is moved freely, so no entrapment. If the muscle is not moved and the eye is not moved, this will be muscle entrapment. It is called force reduction test. Radiographic evaluation, this statement is very important. Nothing is more valuable to the surgeon in determining the extent of injury and the position of the fragments both before and after operation than a good radiograph. Very important, very important. We have plain radiograph in Waters view. It is posterior anterior view. It was discussed in maxillary fracture. Okay, this is the picture of Waters view. We have CT, axial and crown. Very important. This is the coronal cut of CT. This coronal cut we can see from this cut clearly, you can see the orbits of the eye, especially the inferior orbital rim and wall. Very important. Okay, but in this cut, the axial cut, we can see clearly the zygomatic arch and the zygomatic bone and the sphenozygomatic process. Very important. This is the sphenozygomatic process. Okay, we have another picture. This is the coronal. We see here the zygomatic bone fracture and displacement of zygomatic bone fracture. We have that inferior orbital rim fracture and fractured inferior orbital wall. This is the displacement in axial cut of the zygomatic bone. This is fracture of zygomatic arch. Okay, another picture. This is a comminution or complete destruction of the inferior orbital wall, the floor of the orbit, and dehiscence of the globe or dehiscence of the orbital fat inside the maxillary sinus. Okay, this is displacement fractured zygomatic bone. Also, this is fracture of zygomatic arch and displacement of zygomatic bone in axial cut. A treatment. We have no treatment. We have reduction without fixation. We have reduction with fixation. No treatment in cases of minimal displacement with any cosmetic, very important, with any cosmetic deformity or disturbance of in function of or vision, like disturbance in vision, like there is no ophthalmos, no diplopia, no blurred vision, no affection of the optic nerve, and so on. Reduction without fixation. Reduction without, it means that a reduction with need of fixation in cases of if after reduction the zygomatic bone is stable and not return to its abnormal position, so it is not need fixation. We have two classic approaches to reduction of the zygomatic bone. We have what it is called Gills or temporal approach and Keynes or intraoral approach. Okay. This is a picture of zygomatic bone. Okay, so if we need to reduce this part, we can use this approach, temporal approach. We can use intraoral approach. We can use percutaneous or direct approach through the skin. Okay, so we have three approaches: two classic approach, temporal approach from the temporal part, temporal area, intraoral approach or Keynes approach, or percutaneous or transcutaneous approach. First is the temporal approach or Gills approach. This is the shape of zygomatic elevator. This flat end will be inserted through the incision to catch the zygomatic bone and the zygomatic arch if we need to reduce the zygomatic arch from its medial surface. Okay, by another blade we lift, we catch the other blade by the other hand, other part by the other hand, and we lift the zygoma upward and outward until we hear a click sound. So this click sound means that the zygoma is reduced to its normal position. Very important. The other approach is Keynes or intraoral approach. Okay. This is the intraoral approach by an incision above the upper six in the vestibule. Okay, about 2 cm in length. Okay, and after that by dissection by using microprocessor elevator to reach the undersurface of zygomatic bone or zygomatic arch, and after that we use raw zygomatic elevator, and we can lift or elevate the fractured zygomatic bone to upward and outward. very important. This technique have its main advantage is there is no vital structure, no trauma to any vital structure. We have no scar that happened in this approach, very important. Through the skin, we have by two instruments is zygomatic hook or carrot screw. This is the shape of zygomatic, different shapes of zygomatic hooks that used for reduction of zygomatic bone. It is directly introduced through the skin by incision about half centimeter in the skin in the cheek area, and the sharp end of the hook is introduced below the zygomatic bone and can be reduced upward and outward. It is the most common to use the type of reduction instruments used for reduction of zygomatic bone. Okay. The another instrument is carrot screw. It is have a long screw with a handle like a T-shape. This screw is introduced inside the zygomatic bone, and we can use the handle, the T-bar, to move the fractured zygomatic bone to any direction, upward, inward, outward, and so on. So it is carrot screw. This is a picture of carrot screw used for reduction of zygomatic bone. Okay. After reduction of zygomatic bone, if the zygomatic bone is not stable, so we must fix it. So we must use fixation. Fixation can be done with wire osteosynthesis, and it is became a history and not used nowadays. The most commonly used is rigid fixation using plates and screw, and the plates and screw is placed intraoral through the vestibular maxillary approach to fix in zygomatic maxillary part, okay, or in the frontozygomatic suture through lateral eyebrow approach, or in the infraorbital rim through the transcutaneous approach, subciliary, subtarsal or infraorbital approach, or transconjunctival approach, periseptal or postseptal approaches. These approaches were discussed in maxillary fracture. This is a picture of lateral eyebrow approach. Okay, this is 2 mm mini plate is placed in the frontozygomatic area. Okay, another picture. This is the approach to infraorbital rim. We have subciliary incision, subtarsal incision, and infraorbital incision, and we have transconjunctival incision. Okay, this is subtarsal incision. This is about 7 mm from the eyelash margin. Okay, this is a 2 mm mini plate. Okay. This is a case of we use wire osteosynthesis for fixation of the fracture segment. It is not used nowadays. Okay. So the complications from zygomatic fracture, we have malunion and asymmetry. We have maybe permanent endophthalmos or permanent diplopia. Okay, we have traumatic hyphema, we have traumatic optic neuropathy, we have retrovalvular hemorrhage, and we have teresmus